So what we're going to deal with in the next few minutes, and we're going to go until about 11:30. The first portion is going to be on HPV and mouth lesions. Then we're going to divert a little bit on other things. We'll talk about a little bit of dry mouth and X-rays. But here's the next thing. So human papillomavirus is ubiquitous. And human papillomavirus, as I'll show you in just a minute, is amongst us. The map that you see there is a map of the US, and the little peaks are the peaks of population. So as of last night when I checked, there were 323.5 million people in the US, legally, in the US. And that's a whole lot of people. And that's a whole lot of HPV. Let me show you a few things that are going to make you think twice the next time you are counseling patients. So when you hear the term, or we use the term HPV, we are referring to a family of viruses. So they're all DNA viruses, and they're in the same human papillomaviride family. But there's about 113 and counting different types of HPV that have been typed to date. And literally I'm counting because every couple of weeks there's a new type of virus of HPV family that is described. But all of them have the same characteristic that they are hosted by humans and they are transmitted through fluids or direct contact to another human. There's similar viruses in non-vertebrate animals and in other animals, but those are not called human papillomaviruses, they're other papillomaviruses. So HPVs are all over the place, and they are all able to go and insert themselves into the DNA of the host cells. The host cells for most HPV viruses are keratinocytes of the epithelium. And the two most common, well, there's skin and mucosas. Those are the places where people get it. Occasionally people will get papillomas of their urethra or their bladder, but by far, skin and mucous membranes are the two most common. The mucous membranes are genital membranes and also oral mucosa. There's two huge families of HPVs, the good ones and the bad ones. So the good ones we label or call low-risk HPV viruses, and the bad ones we call high-risk HPV viruses. Let me show you some numbers about HPV. But this is pretty scary if you are thinking about personal contact and risk of coming in contact with HPVs. So approximately 50% of the sexually active people will get infected by HPV in their lifetime. 6 million people get infected every year, and 20 million people, or US residents or citizens, are infected at any one point per year in the US. Importantly though, infected doesn't mean that you have a disease actively going on in you or that you will develop a lesion in your mouth. Infected just means that at that point you're carrying the viruses and are able to transmit it. So not all infections result in disease or in actual physical lesion. But including all sites, about 33,000 cases of cancers, cervical and oral and head and neck, are going to be driven by HPV per year in the US. And about 12,000 people in the US each year get HPV-driven cancers. Those are the ones that are proven that are caused by human papillomaviruses. So, who is at most risk for HPV? These are three separate studies that say the first study studied our college population, and it was only studying males, and it was people, actually not college, but single location. And males between the ages of 18 and 73, about 4.5% of that population had HPV in their body at one time point by means of mucosal lavage. The second bullet point here is that at the University of Seattle, college students about 6% of the college students had HPV in their mucosal washings at one point in the semester. And then on the bottom here, the University of Florida, about 70% of the college females that were at the University of Florida had HPV through mucosal lavage at one point during the semester. Also important things and scary things that we learn through this type of studies is that the incidence of having HPV in our bodies or in a patient's body is directly correlated with sexual activity and also directly correlated with smoking and alcohol. The more that people smoke and drink, the more chances of them having papilloma exposure or human papilloma exposure. So, what's the biology of HPV? How do you go from, or how does a patient go, or how does the neighbor go from contact to actually having a lesion? It's a little chain. It starts at the top of this graph with an exposure to a human papilloma virus. Once the patient is exposed to human papilloma virus, and I'm going to use the example of the mouth mucosa, that patient gets exposed to that, the virus trickles itself and wiggles itself through the epithelial cells down to the basal cells of the epithelium. Those are the ones stuck on the basement membrane. Then it pierces through the cell wall, gains access to the cytoplasm of the cell, then it curls through the cytoplasm, gets to the nuclear membrane, pokes a hole through the nuclear membrane, gets in the nucleus, and it parks itself right next to the host DNA. That is called an episomal existence. So at that point, it has been accessed through all of these barriers to next to the DNA. At some point, this HPV that's there is going to clip the DNA, and I'm using gross terms, but it's very illustrative. It's a little bit more complicated, but it clips the DNA, and it takes out a piece of the host DNA, throws it out, and then inserts itself in that DNA. And every time the cell undergoes a cell cycle, what it does, it produces more HPV DNA in it, and it becomes a factory of DNA viruses. So it takes over the machinery and hijacks it to become perpetuated over and over again. So that is called integrated existence of the virus. Then, here comes an important spot. If the virus that infected that cell is a good virus, or a good HPV, or a low-risk HPV, this person or this individual is going to have some type of hyperplastic lesion or a benign growth, like a wart. If the virus that infected that cell is a bad guy, or a high-risk virus like 16, 18, and a few others, then that is going to trigger the process of carcinogenesis, and that patient is going to have this plastic lesion that has the chance to develop into a carcinoma. So at that point, which virus you got infected with is going to be critically important, because you either get a wart or a precancer lesion. Once the cell, its DNA has been altered, it also, the cell as the normal function of the cell, will tell the cell wall to change the signature of the immune or the antigenicity of that cell, and instead of having an HLA or etc., the signature, as I call it, the license plate of that cell, as a normal keratinocyte, that license plate or that VIN is going to change, and it's going to be an abnormal license plate. That abnormal license plate, the immune system is going to detect as not okay. And the immune cells are going to attempt to kill this keratinocyte as part of the immunosurveillance phenomenon. That is when everything goes well. And most people that get infected and have effective lesions of HPV are going to clear the lesions from their body within a year of having the encounter. So most people will do that. Some people in some people, this doesn't happen, either because they're immunosuppressed or because their immune system is unable to identify this antigenic change, or they don't catch, or the immune cells don't catch the license plate that's out there. For whatever reason, it avoids the immunosurveillance, and these people will develop a lesion. And at that point is when we see the little wart pop up, or the little erythroplakia on the posterior pharyngeal wall come up. It is way late. It is up until this point that we see visual changes. But all of this has already happened by the time these things mushroom up. So if a patient is infected with a low-risk virus, the column on the left will tell you that you can always get wart, squamous papilloma, Bruch vulgaris, Hex disease, also known as multifocal epithelial neoplasia, or somebody might also get condylomas if it is sexually transmitted. On the right hand is the type of problem that people will get if they are infected by high-risk HPV. So at that point, usually will be either an ulcerative lesion on the oropharyngeal area, or some sort of erythroplakia, or an ulcer, or some induration. Rarely papillary lesions are going to be high-risk HPV lesions. So here is the typical prototype of your squamous papilloma. This is somebody who had an infection with low-risk HPV. This is what it would look like on somebody's lateral tongue. So this is, some people will use the term wart, intraoral wart. Some people use the term squamous papilloma. There's differences histologically and in the types of viruses, but essentially they are benign HPV hyperplastic lesions or benign neoplasms that will not kill the patient, but they are HPV driven. And I'll talk to you guys about the significance of these HPV lesions. We are changing the philosophy of how we see and how we gauge the relevance of these lesions based on the biology that we have learned. So these are examples of HPV-driven squamous papillomas, and this is another area that is very common. So squamous papillomas can be on the soft palate, lateral tongue, anywhere in the mouth is fair game. But these are by far the two most common locations. And I'll tell you why in just a little bit. Here's an example of Hex disease, also known as multifocal epithelial neoplasia. This is HPV 13 and or 32. Those two are the culprits of this lesion or this disease, and they infect usually malnourished pediatric populations, and they develop multiple lesions. Many of these patients are labeled as having been sexually abused, or they get misdiagnosed as having condylomata. The reality is that HPV 13 and 32 are related to Hex disease. Tricky thing, because you have to trigger, those of you who do pediatric dentistry know that you have to trigger a very uncomfortable talk with the parents and guardians, and it gets complicated. And here is condyloma acuminata. So this individual had oral sex with somebody who was infected with HPV low risk, and they ended up acquiring HPV-driven lesions of the mouth through contact. So those are the good actors. They may not be pretty, but they're good actors. Here's the bad actor. I've shown you this picture 2 or 3 times because I need it to be in your brain. So when you see something like that in a 2mm presentation, you want to act, or 5mm presentation. This is an HPV-driven squamous cell carcinoma. So we have known for years that HPV is associated, or that viruses are oncogenic. EBV, or Epstein-Barr virus, if it doesn't give you mono, it can give you many other disorders. And also, cytomegalovirus has been associated with some low-risk forms of mucoepidermal carcinoma of salivary gland. Herpes 8 has been now unequivocally linked to Kaposi sarcoma. And there's a few others here and there. But in the HPV world, 16 and 18 are the 2 biggies that we are unequivocally linking to the development of precancerous and cancerous lesions. Over time, we have also evolved in the knowledge of HPV So back in the day, when our tools for detecting HPV were not very good, we were only able to detect the presence of HPV in tissue, either if it was there or if it was not there. So we overestimated the amount of HPV presence in some head and neck cancers. As we mature in the tools that we use, we are able to tell if the presence of that HPV is just a hitchhiker or if that HPV is actually transcriptionally active and driving the cell cycle. So now, once we test for transcriptionally active HPVs, we know that there's a smaller percentage of HPV-driven cancers of the head neck area that we used to think before. Now the numbers are increasing, but the proportion is less. So, I talked to you guys about this work from Elizabeth Andrews that linked HPV between couples that didn't smoke, didn't drink, and had oral sex. And this was in 2007-ish or 8 that this was published. So this has been now multiple times proven as correct. And we know also a lot about molecular biology of how HPV works, but it drives the cell cycle of the mitosis into high gear, and it becomes just a proliferation of these cells. But let me go back one. So on the right, we now have multiple tools that we use for assessing the transcriptionally active presence of HPV. And right now we're using either P16 immunohistochemistry to detect for the presence of cells that are active, and also in situ hybridization that detects high-risk HPV types within the nucleus of keratinocytes. And we have to visually see it inside of the nucleus, and that's the bottom, the middle picture. So, do we genotype all HPV lesions that we get biopsy? The answer is negative. We don't. Statistically speaking and epidemiologically speaking, there is not yet enough justification for us to type all papillomas and warts and condylomas for what specific viruses is happening. It may happen down the line on a retrospective basis. We are typing, though, all malignancies. So if somebody has a squamous cell carcinoma, we will type it. But if somebody has a squamous papilloma, we will not type it yet. That may change down the line, but that's where we are. So you will ask yourselves, what is the significance of the typical squamous papilloma on somebody's soft palate? We used to not think much of it, and the books will recommend cut it out. Now we have actual science to support that all papillomas need to be excised from this individual. And I'll develop the why in just a little bit. But what we know from what I've told you already is that by the time somebody develops a wart in the mouth or the skin, they have been in contact with HPV. We don't know which ones, or if only one type or 10 or 50. And B, their immune system is unable to clear that infection of HPV to the point that they develop this lesion. So A, contact with HPV. B, their immune system is not able to clear. Therefore, they end up in time with a lesion. So now we consider these people that develop oral papillomas and warts to be at high risk for other diseases, especially, and more importantly, squamous cell carcinoma that's HPV driven. Why? Why are we saying that? These lesions, HPV driven lesions like papillomas, are not per se premalignant or statistically likely to develop into cancers. But they are markers that the patient was exposed to HPV. And you cannot pick your partner and say, you only have low risk, I'll dance with you. You only have high risk, I will not dance with you. You don't know. Everybody is a package. And with the low risk come the high risk. So it's a mix, and you take the gamble. If you dance with that person, they may have low and high risk, and then you may end up with a problem. But what we do know is that people with papillomas have been exposed to HPV, and we don't know which ones, and that their immune system cannot stop them. So they are at risk of high-risk infection. Here's another example of science that has unequivocally proven that HPV is a transmissible infection between humans. And this is something that has happened. Let me see, this paper is 2 people that had head and neck squamous cell carcinoma, genotyped to the exact same virus, one gave it to the other. Here's another example in which there's cases that have been documented that a female partner has had history of high-risk HPV in her cervix, and the partner has developed tonsillar or oral head and neck squamous cell carcinoma secondary to direct infection from the cervical HPV from the other person. So that is now proven that it happens. So oral sex is definitely a risk factor for developing HPV-driven lesions. We know that HPV-driven squamous cell carcinomas probably are a little different than tobacco or alcohol or sun-induced oral cancers or lip cancers. And physically, they look a little bit different in the location where they present, usually the Waldeyr's ring area. They also are usually more ulcerated and indurated and red rather than white and leukoplakic. And also, people with HPV-driven squamous cell carcinoma tend to fare a little bit better than patients with tobacco and alcohol-driven squamous cell. That doesn't mean that if you, the problem with this is that some people do practice oral sex with multiple promiscuous partners and smoke and drink, and so they would have a triple whammy in that area. So we also know that from the perspective of molecular pathways, HPV-driven squamous cell carcinoma takes one route, and tobacco alcohol takes another route, and sun-induced squamous cell carcinoma takes another route. They share some common links among that, which in this case is highlighted in green. But some of them go one way and the other, and some of the others go in a different pathway. Common areas, they all end in a squamous cell carcinoma, but they have different little areas where they are very idiosyncratically exclusive. So there was a very elegant study done by Mark Lingen and Richard Jordan and others, in which they took about 600 cases, or maybe 400, I forget, a lot of squamous cell carcinomas, and they tested all fashions of HPV presence in these: transcriptionally active, non-active, in situ hybridization, immunohistochemistry, etc. And they came up with the concept of A. They revalidated the incidence of approximately 70% of pharyngeal cancers are driven by HPV, and about 6% of oral cancers are driven by HPV. What does this mean? Oropharyngeal means anything in the Waldeyr's ring area. Adenoids, tonsils, tonsillar fossa, anterior tonsillar pillar, posterior pharyngeal wall, base of the tongue, and lingual tonsils. That Waldeyr's ring is HPV land, and 70% of oral cancers or squamous cell carcinomas in that area are HPV driven. 30% are not. And in the mouth, and that includes floor mouth, ventral tongue, lateral tongue, etc., all the intraoral sites that are not Waldeyr's ring and that are not sun exposed, about 1 in 20 are driven by HPV. So that is not as large, but that means that 1 in 20 oral cancers that we see are HPV driven. That is enough statistically to trigger pathology labs to be mandated to genotype HPV or squamous cell carcinomas for high-risk cancer and see if they're driven, because it makes a difference in management. They do much better. They do relatively better than tobacco and alcohol. So there's there's different ways of testing for HPV. There's saliva washes, there's samples of saliva that can test for HPV. The industry standard is to use tissue testing because that will tell you the location of the transcriptionally active cells. If you do it in a liquid base, if you do it on blood, or if you do it in saliva, it will tell you the presence, but it will not localize it to the specific location that you need to know. And as you know, about 1 year is what it takes for somebody to clear that with a competent immune system. So lots of questions come out of this information. We end up with more questions than we have answers at this point when we're working on it. So, who is really at risk? What do we need to do for this type of people? And all kinds of different wondering questions about my neighbor, or I have a friend who does this. But essentially, this is what we know. A, we know that not all HPVs are the same. We have high risk and low risk. We know that not all contacts end up in a disease or in a lesion. And we also know that not every time that a patient develops a lesion that is worthy is going to be HPV driven. But we know that somewhere in the neighborhood of 6% of oral cancers are HPV driven, and that means that there's a whole lot of people walking around with HPV driven carcinogenesis, which technically is, at some level, considered a transmissible disease. That is scary stuff, if you think about it. So, not all papillary lesions are HPV driven. You can have a patient who has a verruciform xanthoma, or some types of lymphangiomas on the tongue can also be kind of heavily. You can have other lesions like Herpes carcinoma, which is not HPV driven, be a warty white lesion. And that's why we recommend we need to take this out, look at it under a microscope, make sure that this is an HPV before you start wrecking these people's lifestyles when you start coaching them about risk factors. So we don't know who is at risk other than the people that may be in contact with multiple HPVs at the same time. So we don't know who to screen at this point other than the safest thing that we have developed is to incorporate into the written medical history questions about the possibility of orogenital contact with multiple promiscuous partners or with a single partner who is promiscuous. As you can imagine, this is an atomic bomb of PR for practice. And especially if you are in an operatory that's open and you're going to talk to Mrs. Smith about oral sex. That is something that is not quite yet out there in the acceptable realm of behavior. But it is something that down the line we are going to have to tackle because it is real risk for patients. Just like talking about smoking and alcohol, down the line we're going to have to design a way to assess who is the person at risk and how can we deliver patient education for this. Right now what we have done is we preemptively have literature in the waiting room that tells patients about this, and hopefully that triggers some conversation. There's patients that you talk to and you see a squamous papilloma and ask about orogenital contact, and they are happy to report that yes, that's not a problem, and they do that all the time with everybody. But there's people that will deny it. So it's a tricky thing. So another game changer when it comes to this type of lesions is we used to have a bunch of populations that were high-risk populations. We had the smokers, we had the heavy alcohol users, and we had the immunosuppressed patients. Now we have to add the promiscuous oral sex patients or the mouth-to-mouth, open-mouth kissing type patients that are having contact. HPV is sort of like social media. So you may have one contact, but that contact may have 17 contacts. And then it just keeps on going as HPV builds up. So the magic number for patients is 7. Statistically speaking, Anytime that somebody has had orogenital contact with 7 or greater individuals, their chances of having been exposed, statistically speaking, to high-risk HPV is in the 90s. So that's a scary thing. So, high-risk areas of the mouth, we used to have the lateral tongue, ventral tongue, floor of the mouth. Now we have to add areas where mucosas contact together. We used to have at-risk populations too. Now we have to add promiscuous oral sex practitioners. And so the typical orthodontics patient that may have a lesion right here on the tuberosity, or we have another type of individual who will have a lesion in the tonsillar pillar or tonsillar fossa. So right here on the right, there's a lesion on the tonsillar fossa, and the other patient in braces has a lesion on the tuberosity. So those are at-risk populations that we used to not think twice about patients going to the orthodontist office and think of oral cancer screening. That was different. It's like your question about the pediatric patients. So it gets tricky. So the other thing is at-risk behaviors. And that's the uncomfortable thing. I know that it's easy for me to say this kind of stuff on a stage from an academic institution, and it is not a good practice builder for you to go ask somebody if they've had oral sex with more than one person or with promiscuous partners. So high-risk behaviors is also a tricky thing that somehow we're going to have to incorporate into our medical history and interview the patient. So the other question is, do we cut this out or do we not? Absolutely, when in doubt, cut it out. Because we want to know, A, if this is true, if this word-looking thing is truly a papillary lesion related to HPV or completely unrelated to HPV. So we need to know, or the patients need to know, if they have an HPV-driven lesion, because that means that statistically, they have a chance of having been exposed to high risk, and for you, it means that you need to look a little harder and more judiciously at their areas of the mouth that may be high risk for HPV development. So when it's out, cut the mouth. So how can we serve our patient better? We need to educate ourselves. We need to learn about this stuff. We need to be able to answer questions, or at the very minimum, refer them to a document or to a website that's credible, that has the answers for them. Because a lot of the times, the patients are not going to say a word about you, but they will hear everything you remember, and as soon as they head home, they're going to go home, close the door, and open their laptop and figure out if they are at risk. If you at least trigger that, it'll be good. So, here's the next one. HPV vaccines. HPV vaccines are, or the one, is a thing of beauty. So it's making a ton of money for the company that's manufactures this, but essentially is a double-edged sword. It is great. It is very effective for preventing HPV-driven lesions if the person that receives the vaccine, A, is pre-contact, and B, gets all 3 boosters of these. So it's a series of shots that needs to be done in a trio. That's A. And B, it is most effective for people before they have come in contact with high-risk HPV or HPVs. That's why the recommendation is for females between the ages of 9 and 26, and for males between the ages of 9 and 15. How did they come up with these numbers? I don't know. But the important thing is that, and the unfortunate thing, is that those are the populations that insurance companies will cover. If you are not, or if your patient is not inside those ranges, many insurance companies are going to deny the coverage of that, and that is a few $100s worth of out-of-pocket expense. Having said that, how much money would you pay to prevent having cervical cancer or throat cancer? Probably the few $100 that's there. Okay, so that's the good part of it. The bad part of it is that they call it the HPV vaccine. And just like the flu vaccine that we get every year, or you should get every year, you know how the flu vaccine is made? There's a couple nerds with a laptop in the CDC in Atlanta, and they get all the data from the previous year's flu reports. And they get the 10 most common adenoviruses that got people sick last year. They statistically massage it so they can recommend that 2017 flu vaccine is going to include viruses A, B, C, D, all the way to 10. So that means that when you get a flu shot, you are going to be statistically covered against these 10 viruses that cover a whole bunch of the flu that goes around. But it's not 100%. Same thing with HPV. HPV vaccines started with 4. So it was 6, 11, 16, and 18, I think. And that was a quadrivalent HPV vaccine. It has now become a 9-valent flu vaccine, HPV vaccine. So it now covers the same 2 low-risk viruses and 7 high-risk viruses. But that is not told to the patients. The patients get told that that's their HPV vaccine. So patients here, woohoo, green light, no HPV for me. And they don't realize that they've been covered against 9 out of 115. That means that 100 and some other HPV viruses can still infect these people. Now, statistically speaking, they are safer than if they didn't have the HPV vaccine. And it is a good idea to do that. But it's a good idea also to provide patient education so they understand that it is not a 100% shield that they are now immune to HPV viruses. So that's an important thing that I wanted to say about that. And let me switch channels here for a second. If there's any questions about this, this is a good time.
I have a question.
Excellent.
So if a patient comes and they have that wart on their palate, are they contagious? Are they still active? And can they?
Yeah.
Because I had a patient that had a wart, and I sent him to the oral surgeon, and the oral surgeon told him it's just a wart, leave it alone. So
Correct.
it wasn't addressed.
So I'll try to repeat your question. So she had a patient who had an intraoral wart, intraoral, right? Not skin. So who had an intraoral wart, and she recommended for that lesion to be removed, and then the person who they consulted said, nah, there's no need to remove it, correct?
Yes.
Correct. So that is true, and that was the behavior a few years ago before we started learning about all of this stuff. Now we know that A, low-risk and high-risk viruses, or lesions, as they mature through the epithelial normal cycle, those keratinocytes that are infected, as they shed, they bring with it viral particles. That is how it goes from person A to person B. So there is a shedding of viruses from HPV lesions. That is why most patients or most people who have intraoral HPV lesions that are sexually transmitted have it in their soft palate or well-nourished ring area, because that's where the glands of the penis is the most loaded with HPV, and it deposits and contacts the most oral mucosa and traumatizes the area. So to answer the question, yes, HPV lesions, intraoral warts and papillomas, do shed viruses, and they will go on the saliva. And if that person exchanges saliva with another person who has an open wound or who has a tear on their mucosa, genital or oral, that is an open door for that HPV to get and start that chain cycle. So that is another of the reasons why we do recommend that that warty lesions be now excised. Before, we could get away with watching it. We didn't realize of the shedding, because also in the past, people who were immunocompetent, they had a fighting chance of within about 12 months to activate their immune system and destroy these cells that were abnormal, and they will get rid of the lesion and it would, quote, go away. That's how finger warts would work for a lot of people. A lot of people would, quote, outgrow them. It was their immune system actually knocking out the virus. So yes, we know that that is true. That is also the mechanism by which infants, as they are born through the birth canal of a mother with vaginal or vulvar HPV lesions end up with laryngeal papillomatosis. Because as they go through the canal, they aspirate the mucus with HPV, and they end up with laryngeal papillomatosis. So yes, we recommend that that be excised. We recommend that that be looked at, because if it is HPV, that patient needs counseling about personal contact and prognosis and risk behavior. More questions? Yes?
You're talking about intraoral warts, but you're saying that it causes the external warts, like on people's hands and stuff too?
Yeah, so HPV can infect any epithelial cell on the skin or on the
Does
mucosa.
everybody that have warts have HPV? Or
Yes.
Yes.
Yes. Yeah, warts, if it is a verruca vulgaris, is an HPV-driven proliferation. It is benign and it is contagious, but it is an HPV-driven thing. So if somebody has finger warts, that is the most common situation in which I see pediatric patients end up with oral warts on their lips because they bite their nails or they bite their warts and they put them under mucosa. That is also another way in which I see high school patients end up with finger warts with sex and
So
digital
should
manipulation.
the ones on the hands, I mean, should those be taken off too?
They should be managed because they're contagious. Yeah, all warts are contagious. That is how it goes from one person to the other. All warts are contagious. Now, that doesn't mean that if I go shake hands with Johnny in the street, I'm going to end up with warts in my hand if he has warts. Because if I have an intact membrane, I will have less chances of having that problem. Plus, if my immune system is competent, it's going to chop that chain before it gets to a lesion. But in theory, if you were to be immunologically naive, if you take a bubble baby and you have him shake hands with somebody, they can develop that type of problem. So all warts are contagious or potentially contagious, and they're all driven by HPV.
I have another question.
Fire away.
All viruses are carcinogens. So
Not all viruses. Not all viruses are.
can be.
Not even there. Some can be. So if you get viral pneumonia, that doesn't mean you're gonna get lung cancer. No.
But
Only
my
oncogenes.
question was, we see a lot of herpes. You know, is there an issue with that?
Negative. We have no evidence that herpes simplex 1 or 2 is associated with any incidence of malignant transformation of the tissues. Not at all. We do have some history of patients who have genital herpes having had risk behavior that induce HPV transmission, chlamydia, and other things. But HSV1 and HSV2, the herpes viruses themselves are not oncogenic. So they don't induce. Yes, sir?
You have a son or daughter that's 9 years old in that range, you have a back leg or
I put my money where my mouth is. I have 2 daughters, 12 and 14. Both of them are vaccinated. Yes.
Is there a test for HPV, like a blood test?
Yeah, so her question is there a test for HPV? Yes, you can. Usually, though, they are not very sensitive because they're very expensive to do. So when you have a blood test, they can detect the presence of HPV versus the absence of HPV. It is possible that somebody may have a viral load that's high enough to be able to subtype and genotype this, but you would have to have a lot of that in the blood. We can genotype in tissue. So if you were to have a biopsy of somebody with a squamous cell carcinoma of the base of the tongue, we will genotype it, but we will genotype it in a package type thing. So we have an immunohistochemical antibody complex that will detect the 25 most common high-risk HPVs. So if we put it on the tissue and it is positive, we will tell you there is a high-risk HPV virus in this tissue, we just don't know which one. If we need to know which one, we will have to actually culture this and do specific things for each cell, for each type individually, and that is a very costly thing. Maybe down the line it will happen, but it is not out there yet. Yes?
So if somebody's been exposed to HPV and they know of it, and they don't have any symptoms within a year, does that mean their immune system has fought it off?
Correct. So if somebody has been exposed to HPV and they know it and they don't develop a lesion within a year, statistically speaking, correct. They are most likely needing to be thanking their immune system for clearing that infection. And that is the ideal scenario. Yes?
You talk about cold sores or fever blisters.
So, regarding the HPV concept or malignancy?
How contagious they are.
Okay.
What's
All right, so let's talk about that. So, cold sores or fever blisters is another name for herpes simplex infection. It is herpes, and we used to link herpes simplex 1 to oral infections and herpes simplex 2 to genital infections. And so when somebody was diagnosed with HSV2, that was considered a venereal disease, and HSV1 was a social disease because of the promiscuity of the population and the ubiquitousness of oral sex. HSV1 and 2 are now both ways. And so we don't even bother typing which one is what. But they are contagious. And like you remember my usual saying, just like diamonds, herpes is forever. Once somebody has acquired herpes simplex, that person will incorporate the virus into their nerves, and in the head and neck area, in our area, it's usually the trigeminal branch. And it will travel up to the trigeminal nerve and sit in the trigeminal ganglion and stay there for life. And when we have a transient immunosuppression or trauma or injury or something that induces activity in that nerve beyond normal, that virus is going to capitalize on that immune deficiency of that location, go down the nerve, and go and affect the epithelial target that is innervated by that nerve. So that travel from the ganglion to the actual lip, if it's a herpes labialis, for example, that time in which the virus is traveling is the prodromal symptom. That tingling sensation or that pain or that itchiness that people feel when the virus is reactivating and traveling is the sweet times in which antiviral medicines work the best. Because if the patient starts taking antiviral meds, the duplication of the reactivation of the virus is stopped before they develop a lesion. And so that's why we recommend for people to take it at the earliest sign of prodromal, because that's the useful time. Once the lesion has turned into a blister, it just has to run its course. Maybe we shorten it by a day or two, and occasionally I give it to patients if it is their first time, and I'll tell you why in a minute. But once that blister elevates, that blister juice is loaded with viral particles. And if you were, or if somebody was to be in contact with that blister, or the blister liquid, by kissing or oral sex or any type of contact, if that liquid was to land in a non-intact mucosa or skin, it will potentially infect that person, and then potentially evade their immune surveillance of that individual. So greater than 75% of the US population by age 60 are positive for HSV1 and or 2. Not everybody develops the lesions because the immune system stops it. So why did I say something about antivirals even after the lesions have evolved? So we know that antivirals will make a marginal benefit to recurrent lesions after they have become blisters. If you don't catch it in the prodromal stage, it's almost useless. But with the exception of A, it may shorten it by about 4 to 6 hours, the whole episode. Instead of 4 days, it's going to last 4 days or 3 days and 20 hours. And the only thing that I do occasionally is if a patient comes in and they have primary herpetic stomatitis, either pharyngotonsillitis or in the mouth, anywhere in the mouth when they have their primary herpes, I many times will give them a prescription of antivirals because despite the patient education that we provide and telling them that this is contagious, especially pediatric patients don't realize that that is contagious, and they may go to the bathroom after they scratch their lip or their gum tissue, and then they will self-inoculate in genital areas or eyes. So that's why I personally give patients on their first episode antivirals for about a week until that ceases, to prevent self-inoculation, not because I am fooling myself of making it shorter, because it doesn't, but just to try to prevent self-inoculation of that patient onto themselves. So that was the answer to, I hope I answered your question. Good. More questions? I'm sorry, sir. So his question is, how long does the HPV virus survive outside of the body? We don't know. We don't know, and so we are all freaking out using Purell because every time we go to a door, we don't know if we're going to actually slam ourselves with the previous guy's area. So we don't know. That's why we use Purell a lot. Yes. I'm going to fall here. What? So her question is, are we more susceptible to HPV infection through a needle stick than, or an instrument stick if the patient has HPV? The answer is yes. However, the viral load that goes on a needle or the lumen of the needle or the instrument is probably very small. Probably very, very small. So statistically and theoretically speaking, yes, it will enhance the risk, but it's very low. It is not like herpes, for example, that if somebody has an active herpes lesion and you start cleaning their mouth with the aerosol, the airwater syringe, you aerosolize that thing and it may end up in your eyes. With HPV, it's not that much, plus you have to have physical contact. If there is a percutaneous exposure, technically you will have a higher risk, but it's relatively low. You have a question? Yes. So her question is, because we don't know how long HPV exists outside of the human host, if somebody has HPV and they somehow drink from a cup or use a utensil, and then is that something that soap and water will remove? The answer is yes, because HPV will stick by surface tension, and when you use the saponificate, the soap to release it, it goes down. Yes?
For any oral lesion you might see as suspicious, should we automatically refer, or do we wait like 2 weeks and bring them back to see if anything's changed?
So let me, that's another 10-minute answer. Before I run the 10 minutes, are you talking about white red lesions or are you talking about papillary lesions? Any, okay, so that's a 15-minute. Here's the scoop. Here's the scoop. And yes, so her question is, for any lesion that we may see, do we immediately refer for a biopsy, or do we do this, the 2-week recall period, etc.? So here's the algorithm for any lesion. A, if you discover a lesion that was unexplained or undocumented before you saw the patient, and you think that lesion is cancer or pre-cancer, biopsy right away. Right away meaning trigger the biopsy. That doesn't mean that you have to biopsy it within that appointment, but trigger the biopsy. If you don't know for sure if it is cancer, but it's still suspicious, biopsy the lesion, or trigger the biopsy. If you have a little bit of suspicion that the lesion has an inflammatory component or a frictional component or some sort of etiologic factor that is related to trauma, then modify the environment of that lesion to promote healing of the trauma. Say, look for sharp edges of the teeth, look for the denture clasp that's jammed in that tissue, or lubricate the mouth a little bit. Do something to the environment that induces healing of that area, and reevaluate the patient in 3 weeks. If that lesion is still there, then trigger a biopsy. But most of the times, reactive lesions will resolve in about 3-4 weeks. And books would have said 2 weeks. And in my experience, I like 3 weeks much better and 4 weeks if occasionally. But 3 weeks is probably a sweet time. Because A, it doesn't clog your schedule too much. And B, it allows for more cell cycles of the keratinocytes to go and cycle under the new environment to make sure that that lesion goes away. If you bring back your patient and the lesion is 50% improved from where it started at 3 weeks, I many times will give them another 3 weeks, and what they come back with gets cut out. If they come back at 6 week point and it is gone, then you cure it. Every time you cure a patient without a prescription or without cutting, you are practicing excellent healthcare. If the patient comes back and the lesion is still there to any extent, that lesion needs to be triggered for a biopsy. Okay, so that's any lesion. Now let me split it to one more thing. Pigmented lesions. Pigmented lesions are a slightly different beast. So when you see a patient in whom you see a pigmented lesion that has not been previously documented and that the patient was unaware of, then the first step is try to scrape it off. If it's scraped off, it was some debris, some kind of debris. Second step is see if it blanches, because the majority of pigmented lesions that blanch are innocuous. They usually will be blood inside a blood vessel. When you press on it, you displace the blood, the lesion blanches, no need for biopsy. If it doesn't blanch, then you look at an x-ray of that area or take an x-ray of that area and see if there's amalgam in that x-ray. If there is amalgam, good to go. If there is no amalgam, it doesn't blanch, and it doesn't scrape off, and it is unexplained, then that lesion probably needs to be biopsied. With the exception of physiologic pigmentation, racial pigmentation, that you will have as a bilateral and symmetric pattern that you can explain by means of physiology. Occasionally, patients will develop pigmented lesions in sites of previous trauma. So if the patient tells you that, yes, they bit their cheek, and after they bit their cheek, that dark spot came about, then give it another 3 weeks or 6 weeks, and it will probably just slowly go down. Pigmented lesions take a long time to regress, but they should. If they don't regress after the trauma is not there, then those lesions need to be excised, or at least biopsy. Not always you have to excise the whole thing. If you have a 15mm pigmented lesion on the lip, don't cut the whole thing. You can just sample a little bit. And once you know that it is a melanotic macula, don't worry about it. The big deal about pigmented lesions is melanoma. And we used to biopsy everything to try to find melanoma as early as possible. Then for a little bit of a few years, we started thinking, well, these melanomas, they die anyway, the patients with it. So maybe it's not really worth it to biopsy it. That was not very accurate or true. But now we know that it is very important to biopsy lesions that are potential melanomas as early as possible, because immunotherapy works wonders, and it works great when the lesions are early. So if we catch a melanocytic proliferation early, and this patient goes on immunotherapy against melanoma, they have a very good fighting chance of clearing. So that's what. I hope I answered that question. All right.
I have a question.
Yes, ma'am.
If you have a wart in your mouth and you cough on your hand, and you say that the juices from the wart can be listed from the wart, how critical is that?
So if somebody has, let me flip it around a little bit too.
Yeah, because I have a follow-up question. Okay.
Perfect. So if somebody has a wart on their finger and they bite their fingernails, they can put the wart in the mouth. If they have a wart in their mouth and they cough in their hand, they are highly unlikely to put it on their hand. And also the hand is a lot tougher and more thick than any other place. If they have a cut on their hand, there is a chance that that may go in there. But in saliva, there is very transient exposure, and it doesn't stay for a long time, and it doesn't have a very big viral load. So it's relatively low chance and low risk. It's still there, but it's low. Very, very low. So your follow-up question?
Yeah, the reason I asked you is because about 5 years ago, the CDC changed the paradigm about how to cough and where to cough. And today, there's been a lot of coughing in this environment, in this room, and I observed quite a few people still coughing in their hand. That's a concern that I have. And we as healthcare providers really need to be an example of how to cough, and it's not in the hand. When I was in kindergarten, that's how they taught me to cough, on my hand. Now the kindergartners, we want to catch up with the kindergartners.
Well,
And not cough in our hands anymore, and they are back on the hand and in the elbow. Because when you cough with your hand, and you go out here and you touch these doors, and you touch this door, and rub everything, then all of us are infected. So I want to challenge us doctors,
I agree with you 100%. Let's do that. Let's not cough your hand. Excellent. I appreciate that, and I endorse that message. But also, it gives you an excuse to nab a little.
That's right.
So absolutely, cough in your elbow. That's the safest thing to do. I'm sorry, yeah.
You suggest I can use when her doctor or her doctor suggests or insists that they see a patient with an active herpetic lesion?
Correct. So that is a tricky question and a very valid question. And I appreciate how you worded it. What kind of verbiage would you suggest? So her question is, what do you suggest to do, say, or not when you are asked against your will to see a patient who has an active herpetic lesion? So personally, I advise my students and residents that if somebody has a herpetic lesion that's active, to try to, with all types of delicacy, to reschedule that patient if there is an elective treatment to be rendered that day. Historically, people will say that once the crust was formed on the lip, that the patient was not infectious. Or once the blister was popped, that the lesion was not infectious. We have seen now multiple reports that there is viral shedding even when patients don't have these lesions active. So patients who are HSV positive, they shed saliva with viruses all the time. Now, the viral load is dramatically different between active and inactive lesions, or blisters that just pop, or blisters that are already crusted. So if you are asked to do that, then I will say that my response will be, well, I don't feel comfortable doing that. Do you mind doing this one for me? Or is it something that may not happen? But the thing that I tell dental students is I get the patient on my side. Because I tell the patients, Mr. Padilla, you have a lesion on your lip that is most likely a viral lesion that is likely shedding viruses. If you are here and I do aerosol in your mouth and I do my instruments and I touch other areas of that aerosol goes in your eye, you may end up with that thing in your eye. Do you want us to reschedule? And then the patient will say, heck yeah! So that's what I would do. If you feel that there's no receptiveness from your supervisor at that point, and you are in that situation, I will put the patient on my side and say, you know, there is a chance that this may go onto your eyes or nose, and I would hate for that to happen. How about we risk it? And most patients will say, no problem. Occasionally, there's going to be patients that want to be seen that day, and there's supervisors that want to see that patient that day. That's a really tough one, and unless getting fired is in the cards, that's going to be tricky. But if you are forced, like sometimes we will see patients on an emergency basis, and they are oozing all kinds of stuff. And we just are extra careful and try not to create aerosol in these patients. So if you are using a Cavitron that goes splatter all around, or if you're going to be washing with an air water syringe, I will probably switch to hand instruments, and I will probably use a lot of gauze and just clean up, try to avoid aerosol. Wear your protective devices and give them to the patient as a statement that you are actually about to show around a lot of viruses in your face or his face, that's going to go there. So there's no gracious way about it other than get the patient on your team. And ultimately, it's in the best interest of the patient. All right. So, where's Kate? Go for a little bit?
Yeah.
All right. So, let me get some stuff that's good for my teeth. Okay. This one I think we can do in a few minutes. Then we'll have a tiny break, and then we'll do the third round of it. So, I also want to talk to you guys about dry mouth. Dry mouth is ubiquitous. Who has had a patient in the last year who said that they have dry mouth? That's why we're talking about dry mouth. Okay, sometimes patients are just dry. Sometimes there's more to the story. And as you'll see, some of these patients have more than one condition going on. One of them is dryness, but they may have more than one thing going on. Here's an example of two patients' tongues that have anemia. So these two individuals have different types of anemia. By the way, if you think that you can tell what type of anemia a patient has by the fact that they are bald or smooth or wrinkled or not, write a book because that's impressive. I cannot. The only way that I have seen reliable results is through actually having blood done for these people. But the fact that the tongue is bald is definitely a sign of many things. One of them is anemia. A thing that is common, probably in the last 5 years, is patients who undergo bariatric surgery and they don't take their supplements. They many times end up anemic, and one of the first signs that we see is sensitivity of the tongue. So be aware of that as a little tip, that you may have patients that have history of bariatric surgery. They need to take their medicines and take their supplements regularly. Another thing that occasionally will be coexistent with dry mouth is candidiasis, because A, we all have yeast in our mouths. If you thought you didn't, you are mistaken. You do have yeast in your mouths, we all have it. And candidiasis or thrush is only an overgrowth out of proportion of otherwise normal Candida albicans or Candida curzi or Candida tropicalis or whichever Candida you want. But it grows more than normal. The reason why people with dry mouth have a higher incidence of candidiasis is because as we grow bugs on the surface of our mouth, the transit of the saliva as we swallow them is, say, I'm going to make up a number, 2 minutes. People who have dry mouth, the transit of saliva is going to be 15 minutes. That means that instead of having only a minute or two for growth, this yeast will get washed away a lot slower, so they have more time to create a thicker plaque. That goes for bacteria, that goes for yeast, for any bug in the mouth. The lower the transit of saliva, the less washing you have of the saliva, of the mouth, the more chances of growth of stuff. So halitosis is also very common in patients who have dry mouth. This is an example of two different patients who have candidiasis. So on the left, you have a funny looking tongue that only has it on one side. We never know why. People just have the funniest presentation. Most of the times it'll be smack in the center, and there'll be another corresponding palatal lesion. Occasionally, we will have patients that have angular cheilitis, and that is most of the times a mixed infection of Candida and Staph. So if you have patients that do not respond to antimycotic agents on the corners of the mouth, the trick to do is to add Neosporin twice a day, because then that will knock out the amount of staph in that area and help you with that. So the saliva is a very complex fluid, and we call it whole saliva. Whole saliva is mostly water, but not only water. It has mucus, it has proteins like immunoglobulins, it has all kinds of good stuff in there. It has electrolytes. Many, many things are in saliva other than water. That's why when people have dry mouth and they drink water, it doesn't do them much, because they're not actually putting saliva back in their mouth, they're just putting a portion of it. It's magic how from cells, let me go back one. If you think about saliva as a bunch of salivary glands as a bunch of grapes, like this one's here, each grape is connected to a little stem, and that stem is connected to a bigger stem, and a bigger stem, and a bigger stem. And as the gland sucks the plasma out of the capillaries around the acinar structures, it takes the plasma out of the vessel, it transforms it into saliva, and puts it in the lumen of that acinar unit. Then the myoepithelial cells around the grape squeeze the thing like that, and it increases the pressure, the hydrostatic pressure of that liquid, and it makes it go into the mouth. That's the beauty of how it works. Along the way, as that saliva is transitioning from acinar structure to duct, that duct exchanges ions and puts things in there and ends up transforming the liquid from acinar saliva to whole saliva. It is a thing of beauty when you study the biochemistry of this. But at the end of the day, you end up with an awesome oral liquid we call whole saliva. And it has many functions. I'm not gonna spend too much time in the functions, but if it wasn't for saliva, we all would be miserable. And I would have a thicker accent if it wasn't for saliva. So it does wonders, and it is necessary. It is part of the homeostasis, and it creates a very nice environment for the mouth. Just like our conjunctiva and eyes, the mouth is an environment designed and expected to be moist and lubricated. And when it's not, it doesn't like it. So, saliva is going to help you eat, fight bugs, and maintain your teeth by ion exchange, and many other things. But it's not the same as other fluids. Tears are a much better fluid than saliva. And because they are designed to stay there and maintain their integrity for a longer period of time, they gain that through a layer of lipid that's on the surface. So in tears, you have right next to your cornea, or your eye, you will have a layer of mucus, then a layer of water, and a layer of fat. That fat is a sort of waterproofer that keeps that moisture in place. Saliva lacks this fat. And that's why it doesn't stay as long. So we have to produce saliva a lot more. And here's the spit meter. We are out of the factory calibrated to have a lot more saliva than we need. So we have an excess of saliva normally. And we come out of the factory with a full tank of saliva projection or production, and life is good. If you are dehydrated, or if for any reason your output of saliva becomes less, you don't care, you don't feel a thing until you reach the red line of your symptoms. So anywhere from red line to full, you are fine. It's like you hurting your finger. If you hurt your finger, you realize that you have a finger. If you don't have any injury in your finger, you don't even think about it. Same thing with this. As long as you have from full to red line, saliva is no problem. Once you reach a critical point, then you're going to have symptoms and they become exponentially worse the less saliva you have. The point of this is that most people begin their lack of saliva life before they realize it. So you've gone from full to red over a period of years, and it is only in 2016 that you feel, man, my mouth is dry. But it's been cooking for a long time. So that is what people will call dry mouth, when you have the sensation of less dryness. What we do is we measure the output of this saliva, and when it's less than expected for that person, we call that a fancy name called salivary hypofunction. So I'm going to just briefly explain here that objectively we measure the function of the output of saliva, and when we measure that we call it sialometry, and we come up with little numbers. But more importantly, we listen to our patients, and our patients will tell you that their mouth is dry. That's what matters. So subjective complaints of dry mouth are as important, or sometimes more important, than the sialometry that we can do. So, who can get dry mouth? Yes, statistically speaking, if you look at this picture, the lady in the center is more likely to get dry mouth, but the answer is any of these people can get dry mouth. Anybody can get dry mouth. Statistically, you are more likely to have dry mouth the older you are. Females have a higher incidence of that. And also, people who are on a ton of medications. The more medications, the more chances of having dry mouth. So, the most common cause of dry mouth in the United States is polypharmacy. If you look at your patient's medical history, when you take their medical history, there's probably 4 to 8 medications they're on. If you read about these meds, half of them are probably dry mouth induced. So that is what we're doing. A lot of the times, patients are over-medicated and they can come off of a few things and do okay. But a lot of the times, this is what keeps people alive. So we are in a non-negotiable situation. We cannot get rid of medications. How do we diagnose dry mouth? Well, we ask the patient. They will tell us that their mouth is very dry. Their speech changes, their oral habits change, etc. But we can also measure the output of saliva in some of these people. So we measure the output of saliva in 2 ways. What we call stimulated and non-stimulated. Unstimulated saliva, or normal salivary production, is when you just have the patient lean forward and spit in a cup, and then you measure how much saliva they put out in a period of time. And you do the math to report milliliters per minute. Stimulated saliva is the same concept, only that patient needs to have some sort of stimulant in their mouth, either a piece of gum or a piece of paraffin wax, or you can be messing with their tongue with a Q-tip or stimulating their soft palate so they can produce saliva. And then you measure the same thing in milliliters per minute. Most patients will put up with about 5 minutes of spitting. Some people will get sick of it after about a minute, but it's usually somewhere about 5 minutes. And this is how you do that. So sialometry, or these numbers, are useless when you use the number of the particular person to compare to normal. Because, say that I output 1.5 milliliters per minute unstimulated saliva, but I feel fine, then don't mess with me. I'm okay. If I output 2 milliliters of saliva by volume and I feel dry, then I need help. Help me get better. So the output of this patient compared to populations is useless. It is extremely useful, though, to compare the patient in time. So if you have a measurement of sialometry on January of 2016, and you compare that to July 2016, and so on every 6 months, the trend that this patient is going is extremely valuable data. It is useless to compare two populations, but the patient for themselves a long time is extremely valuable to use as a comparison. So the trend of what happens is key. Here's what happens in patients. The two bottom lines, purple and red, I think it's purple. The purple and red are patients who have xerostomia that doesn't change between status quo or unstimulated and stimulated. That's critical information for us to know. The change from unstimulated to stimulated. And the other two lines, green and blue, are patients who have changed and increased their output once we stimulate their mouth. And that is key, because if you are going to give a pill to a patient to stimulate salivary production, the only people that are going to respond and benefit from that are blue and green. If you give this pill to somebody that's red or purple, you're just making their urine more expensive because their gland is unable to output saliva. So those people, we have to do some more things. What do usually people complain of when they have dry mouth? This is the list. So anywhere from speech impediments to halitosis to frequent biting of their cheeks or tongue or lips because the tissue doesn't wiggle out of the way of the teeth, or they catch it, or they have difficulty eating a cracker, that's the cracker sign, or they have to drink constantly water. Any of these things is potentially a problem. Frequent yeast infection. So how do we treat these people? We have to find the cause of the problem. If the cause is a medicine, take that away or exchange it. If you cannot exchange that, then that's okay. We can do other things. But if you can revert the etiology of somebody's xerostomia, then the patients cure themselves. You don't have to always prescribe a medicine to somebody to get it better. If you are actually just removing things that are causing the disease, that's great. So, we want to restore the functions of saliva in these people. And if you think like my brain does, in very simple terms, saliva needs to lubricate and hydrate. Those are two important concepts when it comes to helping our patients feel better. Hydrate is the amount of moisture that is given to that oral environment. Lubrication is the amount of viscosity of the liquid or the amount of decreasing of friction between two tissues in that oral environment. And they're very different because water is a terrible lubricant. So when patients try to help themselves, when they have a sensation of dryness and all they do is drink water, they are not helping themselves very well. They are hydrating themselves very well, but they're not lubricating their mouth. Keep that in mind for the next couple minutes. So, we have to eliminate the cause at all costs whenever possible. We need to stimulate salivary flow if their salivary flow is able to be stimulated. If they are in the group that changes from unstimulated to stimulated, then that person needs to be stimulated chemically or physically to produce saliva. And also, we need to make sure that we protect their oral tissue. So we need to give them fluoride supplementation. We have to keep their good hygiene and also make sure that they don't develop issues with dryness. Especially incisal edges of teeth are very prone to chipping off when they dry out. So, determine the cause, eliminate the cause if possible, and then go from there. Remember that the saliva is a fluid that has a watery component and a mucousy component. Sometimes people will have lack of watery component, and their saliva is very frothy and bubbly and sticky. Sometimes they will have plenty of watery component and no mucus. And then they'll have plenty of fluid in their mouth, but it doesn't lubricate as well. So depending on which one is lacking, you have to supplement that lack of whatever they don't have. And you protect the oral tissues against desiccation, and you need to lubricate. So here's some important things. If you think of the mouth environment as this room, for example, and the oral environment, the walls and the ceiling need to be coated with something to have proper function. This coat, usually in saliva, will be mucus and then fluid or water. We cannot do that. There is no liquid that we can give patients to fix that. But what we have done is we have figured out that patients need to have a dual management of salivary or lubrication components, hydration and lubrication. Also, it's pretty common sense that you want to avoid things that are going to pickle the mouth. So if somebody loves eating chips with vinegar and salt, that is not what they need to be doing if they have a problem with dry mouth. They need to be eating other things. Caffeinated beverages, carbonated beverages, alcohol, and acidic stuff is going to create a problem with that. And also, bottled water. Bottled water is relatively acid, and that's why it tastes so well. And it creates a relatively acid environment in that area. So here's another important thing. Remember what we talked about when we were talking about the physiology of salivary glands. The glands take liquid from the serum and make it into saliva. If a patient is chronically dehydrated and is the type of person that only drinks 2.5 glasses of water in a whole day, they don't have enough fluid to give from the blood to the gland to make saliva. So they are essentially wasting a perfectly good salivary gland that doesn't have raw material to output saliva. If these people get properly hydrated, there'll be enough fluid to give to the gland to make it to saliva. So good hydration is key. Also, moisture environment. Sometimes patients will tell you that when they go to sleep, their mouth turns into a desert. And these people may have sleep apnea, or they may use a CPAP, or they may sleep with their mouth open. So many times, if they have a CPAP machine, make sure that their moisturizing component is working fine and it's clean, because otherwise they may develop a yeast infection from it. Also, cold mist humidifiers are fantastic for people who have dryness of the mouth and eyes as they sleep. Have them started about an hour before they go to bed, sleep with the door half shut, and that usually will moisturize them a little bit more. And then you want to supplement the lubrication of these people. Most patients will reflexively have a bottle of water or something with water and sip constantly in that thing. What these people are doing, unfortunately, is they are sipping 1/2 ounce of water, moisturizing their mouth, and swallowing it. Every time they do that, they scrape away the mucus that was lining that mucosa, and it is making it less lubricated. It is temporarily very soothing, but once they swallow, there's no more mucus, and they feel drier and drier and drier. So it's a vicious cycle. The sippers are going to have a problem. So I'll show you how we use the water management for improving this condition. And then we also use supplementation. And the best thing that I have found for this is olive oil. So I'll show you how I tell patients to do this in just a minute. So avoid pickling things. And this is what I tell them. Here's the sequence for managing dry mouth if you cannot use medications for that, or if you rather do non-pharmacologic management. I tell them that quit sipping water, they have to chug water. So they would have to take, say, 4 ounces of water or 6 ounces of water, chug it down, and once they're down with that water, put away the container, take a tablespoonful of olive oil, put it in their mouth, and rinse it for 2 or 3 minutes and spit it out. That will give them A, hydration through the water, and B, once that water goes down, they coat the inside of the mouth with oil, they spit it out, and that will allow for a much better lubrication of that mucosa. that lasts a lot longer than water. If they don't like olive oil, coconut oil works great, lard works great, any edible oil or fat will work. Probably bacon will not work. Mucus, if we have mucus, we would use it, but there's no good mucus that we can use for the mouth. And the only thing that you need to tell your patients is the oil that they eat or the lard that they swish with, they need to swish and spit it. If they swallow it, it's going to induce diarrhea. It can be pretty bad. So swish and spit, and the more they use in their mouth, the longer they keep it in their mouth, the better. So if they just flood their mouth with olive oil and hold it for 5 minutes, as they spit it, their mouth is going to feel like a baby. And they do that about, PRN, but at least every couple hours to keep that mucosa lubricated. They think that you are genius. So you'll help them a lot. You also want to avoid trauma due to desiccation. A lot of these people will have chipping of incisal edges because the environment of the mouth is so non-lubricant that the edges of the incisors chip off, and then they become a sore area by just irritating that mucosa a whole lot. Candida is another thing that happens in patients quite a bit as well, so you can manage that with candidiasis. Drugs. This is another thing that for those of you that at some point need to use drugs, this is what I do. There's 2 drugs that I would recommend, pilocarpine and cevimeline. Cevimeline is a newer generation medication. It is a little bit more selective for the receptors in salivary glands, but both of these medicines will stimulate most of the receptors of endocrine glands. So these people, my patients call them the sweat pills, because these medications stimulate all receptors, and they're gonna have more saliva, more sweating, more tearing, more mucus production in their nasal areas, and vaginal discharge. So everything becomes more. The problem with that is that these patients also have higher incidence of dehydration because we're using that water. So they need to keep well hydrated, keep the oil, and take their medicines. The less the dose that you use that fixes the problem, the better for these people. Pilocarpine has a much shorter half-life, so if you want to use it just in and out, in and out, in and out, on a reliable patient, that's great. If you need to have the patients on a longer base, then Evoxac is probably the way to go. Most insurance companies will force you to go through pilocarpine first, and then they will authorize the Evoxac. But that's the dosage right there if you want to use it. So we're going to take a little break, and then we'll talk about radiography.